Hi everyone, welcome to today's part of DIMH 2023. I'm Leah Ali, and you'll be joining me and Lavi and Joe, who will introduce themselves shortly, for our session today, which is on who pays for what. So this came about when Becky and I were talking a few months ago, and Becky had this idea about this whole theme for these conference days around money and the relationships to digital mental health. And my work has spanned quite a lot of different arenas, as has Lavi's and Joe's actually, and you'll hear more about that shortly, in both frontline digital health, so providing NHS services, particularly around kind of service design for me, and then also in industry and also at a policy level is sort of things that I've done. And this issue around who pays for what is a really important one. It's something that kind of, runs into where does the research funding come from? How does that relate to actually when you are trying to create policy funding structures that are going to be impactful and going to really have good outcomes for patients. So we're really, really delighted that you're all joining us for this today. Just a reminder that this is being recorded, and also to ask you to please engage, participate, please put questions in the chat, and we will hopefully be able to, we should be able to ask you to come ask those yourselves, but if you don't want to, then we will find other ways to make sure that the areas of interest and things you want to know more about from the three of us get covered. So you've heard a little bit about me and the sort of things that I do, and I guess the only other thing to know about the way I've approached my work is that I've come very much to a design-centered way of thinking, so using design thinking in how I approach what I do. And that's relatively recent. That's been in the last sort of 5 to 10 years. I think I was doing pieces of it beforehand, but I didn't have that formal structure, and it's really helped me to sort of understand that a bit more, and I bring that very much into my policy work as well. So I'd love to go to Lavi first. Lavi, would you mind introducing us a little bit, and perhaps at the end, if you could just give us a little bit of your perspective on where to start this conversation around who pays for what? Oh, you're on mute, Lavi.
Thanks, Leah. It's a pleasure to be here and welcome all of you. I am presently an assistant professor and a faculty at the University of Colorado in the Department of Psychiatry. In addition to working with state and federal government agencies in the area of behavioral health, holistic wellness, and tobacco cessation, I'm also involved with the Innovation Center in our university, where digital innovation and digital therapeutics is being developed in a big way. I'm very happy to be here. And I guess we could start with the biggest problem that I see even today, access, and how maybe digitalizing the mental health services could improve that situation.
Lovely, thank you. And Joe?
Yeah, hi everybody. I'm Joe McDonald, a psychiatrist by training, in the NHS for 40 years, now retired from clinical practice. I was formerly National Clinical Lead for IT brackets mental health during the £12.7 billion national programme for IT, which we run in the NHS. Perhaps more relevantly, I'm now medical director at a CBT for insomnia service called Sleepstation, where we do CBTI for 50,000 people a year online. And since this is about money, we do it better than they do it face-to-face. And we charge about 10% of what it would normally cost. So it's a genuinely digital service. I think the biggest problem I see at the moment in terms of digitization of mental health is that nobody wants to. People are perfectly happy doing it the way that they've always done it. Certainly in the NHS, we are doing it pretty much how Hippocrates did it 2,500 years ago.
What do you mean people are doing it the way they've always done it, Joe? Do you mean in terms of not wanting to use digital? Or
yeah, there's the vast majority of mental health services are still your GP sends a letter, the psychiatrist writes to you, you get an appointment to go up to the mental health facility, and you spend quite a lot of time telling the psychiatrist stuff that's already written down in your GP record, and it's Byzantine in its processing. So I'm a child psychiatrist by background. I would spend the first session of a patient with ADHD explaining how to fill in a Conners rating scale and getting the parents to take one into school, bring it back. And that entire hour could be automated, but we don't do it like that. We carry on doing it the way that we've always done it. And I really don't know why. The work we've done at Sleepstation, the patient clerks themselves in, takes their own history, rating scales are filled in. So by the time we get to talk to them, we know pretty much everything we need to know to design their program for them. And some of the very basic stuff that we do, I mean, consultant psychiatrist on 100 grand a year, doing the work of clerks, it's nuts. And yet we still do it that way for the most part.
Thanks, Joe. I think it's really interesting what you're saying about people wanting to do things in the same way and what the drivers are for change. Lavi, I was wondering if I could bring you back in here. Very much from the kind of, we were talking a little bit just before the session started about the sort of academic work that you've done. Do you see a sort of pipeline, kind of how research works, and what's the importance of funding of research in order to drive that change? I wonder what your view on that was.
Yes, and it's been a sad state till more recently, where it showed that it took about 17 years for any research to be actually applied in real world. And so there's been a huge movement towards fast tracking this process. And just this month, we've applied for a grant where we have to develop, and suggest and develop a digitally based solution in the area of behavioral health with a turnaround time of less than 3 years. So between 1 to 5 years, it should be operational and out in the real world, doing what it's supposed to do. So, but research is a big part of it, just so that we ensure it's a scientific process. And with the huge influx of digitally based solutions, and there's a lot of criticism on whether it is evidence-based, okay, it's engaging, but does it do what it's supposed to do? Does it follow a, evidence-based approach, scientific process? And so do we have a checklist? So that's, again, a paper we are writing where we could say, okay, this is a checklist for you, for all developers of digital health solutions to go by and see that, have you covered these points so that it really does justice to the person using it? And that's where research, yeah.
That's interesting. And what about, see, even when you say 3 years, that still sounds quite long to me, actually. If I think about product development cycles, where I've worked in industry, and you look at adoption of technology in other sectors, 3 years still feels like a long time. How do we square that? And how can we, what do you think needs to happen in terms of encouraging funding in the right streams? It comes back to this question of who pays for what? Where do the charities fit? Where do the academic institution, big research funding fits? What needs to come from central government around core services? The dividing line to me feels like it's quite blurred these days.
So I believe the marriage between industry and academia would actually be the right answer for this, which is already happening. It's just because those two have been viewed forever as two opposite sides of the spectrum, right? Industry is all about profit, make money, and how can you turn around? Okay, you're developing a solution, forget about the philanthropic aspect. How much X returns am I going to get? In the academia, it's more about be thorough and make it, it has to be controlled, and you have to be ensure that you get the results. It's not confounded by any other aspects. So the marriage between the two, I guess, is what's happening right now, where you have the power of the, driven on the engine of the industry, but you have the scientific rigor of the academia, where you can get a solution in a quicker time, but with a more scientific validity, I guess.
Joe, do you want to come in on that? I guess you have a view around that.
I certainly do.
Yeah, I thought you would.
The thing about the NHS is that unlike other industries, we have outsourced IT strategy to the feds, and they've been really bad at running, by which I mean the government. Most industries, banking, the airlines, hospitality, etc., they've done their own IT strategy. We have outsourced our IT strategy to the government, and consequently, we've developed a sort of feudal financing system where a new leader comes into, let's call it the centre. You might call it Connecting for Health or NHS Digital or NHSX. But the leader is allocated the power to allocate funding to digital projects up and down the NHS in England. And this fosters a culture in which you must follow what the leader says or you don't get any money. And consequently, for 20 years, money has gone to things where it didn't ought to, and that we now have an absolutely stagnant marketplace in digital in the NHS. And my view is that the problem would be solved by dissolving central control of NHS IT and just handing out the money to the hospitals and the GPs, and they could get on and sort it out themselves, much as other industries have done. So who pays for what? Well, the people who are using the digital tech should ultimately be the customer and not a government agency. There's my view.
That's interesting. I mean, do you think there are some things which need a central drive, not necessarily control as such, but I'm thinking of things like setting standards, putting in place the kind of enablers that allow different sectors to innovate. I mean, that is definitely my view. I'm biased.
So when we invented electricity here in Newcastle, it was a requirement that somebody would standardize on 240 volts and 50 hertz. And that was Charles Hesterman Mertz in 1920, whatever, when that went into legislation. That meant everybody could make vacuum cleaners that worked in Newcastle and London and Bristol and Wales and all over the British Empire. But that's all the government needs to be doing is standards. It didn't ought to be making toasters and vacuum cleaners or telling you which vacuum cleaners you needed to buy, which is where we're at, unfortunately. And consequently, we're all buying really expensive Kirby vacuum cleaners that were out of date 30 years ago. I've murdered that metaphor, haven't I? Sorry.
I mean, for me, that fits quite nicely with the sort of design thinking-led approach that we've taken to some of the sort of big strategic system design type work I've been doing at the RCA and in NHS England. So, for example, there's one piece of work which was digital heart health strategy, which took a full user-centered design, discovery-led process, and worked with multiple user groups, including the national cardiac networks, and not trying to define exactly what should be done, the nuts and bolts and going for the technology. It was much more about what are the key driving problems. It's really the problem framing and getting that problem framing as tight as we can in order to then stimulate testing, prototyping, and a marketplace that actually can address that. So definitely for me, in all the pieces of work that I've done and am doing, that kind of really high level problem framing is key to making sure the money goes as far as it possibly can. I've worked in multiple places, industry and NHS, where, and I know you have too, Joe, the money has frankly been wasted because that problem framing has not been done correctly up front. But I also think it's sometimes at odds. I'm interested in your view on this, Lavi, especially kind of with some of the work that you've done. I think it's sometimes at odds with the scientific method. And that is definitely something that I've seen on my master's course at the Royal College of Art, Healthcare and Design, which has the class. It's fascinating. It's a great course. You should look it up. It's half designers and half clinicians and engineers. And it is very deliberately a massive culture clash of creative people and people who have been trained in scientific methodology. But the sort of opportunity that you get when you do that, you do force people out of their comfort zone, and actually how you can get to new ideas which then need to fit into the scientific testing, because we cannot get away, things need to be safe, etc. But I think we sometimes have a bit of a I don't know quite what the word is, a bit of a false sense of we must do this differently in health because of patient safety, whereas actually car manufacturing, you've got to make sure you don't kill people with your car either. And actually you have to have that blend of the ability to allow creative ideas and creativity to come up at the same time as being able to understand what is going to be safe, what is going to be tolerated in various aspects, production line, etc. I would be really fascinated if anybody wanted to come in with anything, or particularly kind of global perspective. I know certainly for Joe and I, we're taught, Joe has much more experience than I do, especially of kind of more global things. But I would love to know how the situation in different countries influences how this work sort of progresses. Does it lead to literally different solutions coming out because the drivers of the system are slightly different? I'm really fascinated to hear from other people on this. Does anybody want to share anything?
This is a great segue, Leah. So we've got Craig asking a specific question related to something you were talking about, but also Craig being originally based in America, and we also have Chris from Australia. So I'm sure they'll both want to weigh in. Maybe Craig, perhaps if you wanted to go first, because you did have a question in the chat, and then we can segue America, Australia.
Okay, very good. So it's good to be here. Good to see all of you. And Becky, thanks again for your work in putting this forum together yet another year. Leah, I was reflecting on the point you made about the design, and forgive this background noise, you guys, the design thinking approach that you've taken when you think about these problems, this area, and you talked about the framing of the problem. So, and of course we know that the solution is going to be a direct outgrowth of the problem. If you misdefine or misframe the problem, then you get a set of solutions that are suboptimal.
Yeah.
So, a lot of our emphasis in the current system is around sickness and illness and treatment, which is a highly profitable area, to wit money. But could it be that we have the dilemma we have because we are misdefining the problem itself, or defining the problem too narrowly? And would we do better if we opened up the lens of the problem statement to be as much, if not more, wellness and prevention than this kind of narrowly? It doesn't seem narrow, I don't think, to many, but when you look at this topic, that we're so focused on treatment and illness to the neglect of broader wellness and prevention creates a lot of the problem, it seems to me. What are your thoughts about that?
I think Lavi has got some thoughts.
Greg, that's what I totally agree on it. And that's where the whole attention, even in our university, not, one among the many, is the emphasis is turning towards prevention, because that would reduce the burden on the healthcare by, reducing the number of people who actually need, who go to that stage. For example, the director of the counseling director of a premier university, actually, when I had approached her as part of my customer exploring, customer discovery process, I said, okay, what sort of situation, what sort of digital application or solution would you, really need? She says, students come to me when they cannot handle anything anymore on their own. So we need something which would help them much before they reach this stage. So I totally agree. I'm on board.
There's some really interesting work from Australia. There's no one from the Black Dog Institute on the call. Is there today? Oh, I'd love to hear from you if you were there. So a colleague of mine that I trained with at the Maudsley, Dr. Sam Harvey, he's been leading some work at the Black Dog Institute, particularly around this area. So interesting talking about funding, because some of this was government funded, particularly around the acknowledgement that there was a problem with blue collar workers. So specifically that term was used. who were having high levels of sickness rates and experiencing anxiety and depression. So very much related to kind of an occupational health strategy. And they did some work in digital therapeutics and have a lovely offering called Anchored. Actually, the original format was called Headgear and very much tailored to that specific group. So the language was very tailored to the target population with some really, I think Sam's got the only evidence like this in the world, but I'm not sure if that's quite correct or not, of having something that, an effective digital therapeutic that operates quite high up the line in someone's disease course. So using sort of epidemiological evidence, finding a target population, and then proactively giving them access to this digital therapeutic, they were able to reduce the rates of people converting to a diagnosable anxiety and depressive disorder by significant, we're talking significant numbers. And the cost of developing that intervention is dwarfed by the costs of actually preventing those people leaving the workforce, let alone the impacts on their lives, etc. But that takes I think it takes quite a lot of bravery to be able, on the part of multiple people in that chain, to be able to say, look, we don't quite know what the outcome here is going to be. And it is difficult to often prove that outcome chain, but being able to get to really good quality evidence-based measures like that, I think is a real achievement.
Leah, while we're talking about money, I'd like to introduce Milton Friedman, not my favorite economist, but he said there were 4 ways to spend money. 1, your own money on yourself. You're buying a coat, so you buy a really nice coat, but you won't pay over the odds. 2, your own money on somebody else. You're buying a birthday present for somebody. Again, you might not spend as much on that coat as you spend on your own, but you'll still buy a decent coat. Thirdly, someone else's money on yourself, in which case I'll have a mink coat. Thank you very much. And finally, the way we spent money in the National Programme for IT, somebody else's money on somebody else. And that's a big problem. People spending money on digital stuff that they won't actually be using. And that's at the root of many of the problems that we've got in digital in the NHS.
Interesting. Thank you. Thank you, Joe. Does anybody else want to come in, or is there another question, Becky, that we wanted to go to?
I've got a couple comments, but I'll see if anyone wants the floor, if they'd like to say something.
Yeah, happy to jump in, Becky, if that's okay.
Yeah, it's a great time.
Yeah. Hi, everyone. Chris Boyd-Skinner. I'm from Australia. Well, good evening. It's 7:30 p.m. over here. I work for the Australian Digital Health Agency. I've been a public servant for the last 6 or 7 years. I'm a clinician by background. Most of my experience has been in trauma and intensive care nursing. But for the last few years, I've been working in digital mental health, and particularly around digital mental health standards. So the Australian government's developed up a set of great digital mental health standards which apply at the level of the service provider. And we're sort of just going through that phase of implementation and uptake of the standard. So it's a really exciting time for digital mental health in our country. Look, I mean, mental health continues to be very much one of our nation's most pressing issues, just like it does, around the rest of the globe. But we've had a recent change of government here in Australia from Conservative to a Labor government. I think that was around about 12 months ago. And with that, in the last budget that was handed down in May this year, we've seen unprecedented investment both in mental health, but also in digital health as well. So the Australian government committed somewhere close to about $590 million for mental health reform and suicide prevention for the next 12 months, which is an extraordinary investment. And I think that will lend itself to being quite a transformative piece that they're hoping to sort of set the groundwork for quite long-term and systemic change within our mental health system in Australia. So that's looking at things like supporting workforce shortages. So quite a high portion of that budget was allocated to alleviating that bottleneck for the psychology training pipeline, and some of that dedicated to further investments in training psychologists up to deal with digital interventions. There's also quite a high portion of the funding for tailored support as well. And what I mean by that is looking at extending mental health and suicide prevention services to various diverse communities. So looking at our First Nations people with eating disorders, young people, people with disabilities, and also people who come from culturally and linguistically diverse backgrounds. And that's the first time we've seen that, you know, in forever, effectively, that there's a real targeted approach to looking at minorities and also looking at people from different culturally and linguistically diverse backgrounds. Interestingly, digital mental health services only had a very small amount of that initial funding. So around about only $9 million was committed. So, you know, obviously not as substantial as some of the face-to-face stuff that the government's currently focusing on, but they are making some changes to our national digital mental health platform called Head to Health, which is basically a whole heap of digital mental health services in a central national repository. Now, on the back of that $500+ million announcement, there was $1.1 billion in the budget over 4 years for digital health more broadly. Now, again, while that's not directly related to digital mental health per se, what we're seeing is some really targeted funding for the modernisation of our national electronic health record. It's called the My Health Record System, so moving from like a static document type service to a HL7 FHIR-based system, so sort of bringing that atomic data to life, which is very exciting. And the other big piece is around interoperability. So looking at ways in which we can make greater healthcare health information system interoperable. And I think this is a really important point, particularly in the context of mental health care, because I think we all know pretty well that people who suffer from mental health conditions and, you know, have substance misuse issues can often be quite re-traumatized when they're moving from one clinician to another. And so a better connected healthcare system, which is quite interoperable, will, you know, support better continuity of care. Now, the final thing I'll say is, you know, with such a large pot of money, we've got this incredible opportunity before us, but we've also got a really massive responsibility to not squander it. And Joe obviously made some good comments earlier on about the perils of having the feds in charge of such a huge amount of money. I think two things that the government has really focused on in their messaging is thinking about the decisions and strategies that we apply to this funding, really focusing on a couple of key things. So safe and high quality care, and also consumer centricity. And we've been talking about consumer designed and consumer led care, and that care that's informed by lived experience for such a long time. But I think the messaging really signals that they're looking at ensuring that a lot of the decisions they make are consumer centric. So yeah, it's a very exciting time to be working in digital.
How are they actually trying to do that? How are they actually trying to make sure? I am always slightly skeptical, because I've heard people say they tried to make things person-centered for like several decades, not as many decades as Joe's heard it for, but slightly.
Yeah, exactly. So I think in the context of digital mental health, the standards that we've applied and are being taken up quite well across the country have provisions in there in relation to partnering with consumers. So there's a whole pillar of that set of standards which is focused on ensuring that consumers are at the center of the design of services, that they are actively involved in the governance of services as well, and they're also involved in evaluation of any kind of digital mental health service that's accredited to the standards. More broadly in digital health, and I suppose across healthcare, we're starting to see a lot more collaboration and co-design with consumers when we're thinking about the national products that we deliver as part of the digital health agency. So that national electronic health record that I mentioned, we've got a whole host of different kinds of consumers with lived experience, mental health, and other types of lived experience with digital technologies. And we've been engaging them from a very, very early point in the design and the delivery and the rollout of different digital health technologies across the country. So I think it's shifting, but I agree there is a sense of skepticism there as to whether or not there is true co-design principles being applied.
I mean, having spent my entire career in some form of shared care provision and service design, one of the things that, you know, I started off from a very, you know, my digital career started in patient health records, actually. And you know, that was very much about patient empowerment, shifting the dynamic in the power dynamic in the therapeutic relationship, etc. And one of the things that I've understood more, and again, the design thinking, learning about design thinking has really helped me, is to understand that actually it's as important to think about all of the users in that pathway. And I'm talking about clinicians, admin, anybody else who is interacting in some way with that, as well as the patient and as well as the person and carers. All of those user perspectives are vital to getting the right sort of implementation. So, for example, another national program that I work on, which again I know is very close to Joe's heart as well, having done lots of the pioneering work around this, is the Shared Care Records program in the UK. And I work on this because my frontline clinical job is seeing patients who are referred by the neurologists. And in the service that I work in, there are, we have got ridiculous waiting times. We've got people ending their lives by suicide on the waiting list, but they have mostly been managed in a very medicalized model. And actually, in order to make sure that they are getting a holistic biopsychosocial formulation and management, it takes quite a few different pieces of transformation, actually. There's looking at the digital enablers. So yes, we can give them digital therapeutics, whatever. They need to have assessment from people who understand how to do a biopsychosocial formulation. But really key is actually the physical health providers understanding where their deficits in knowledge are, or understanding that there's a problem that actually they may need a different perspective on. And just showing them the records on their own does not do that. So it's a step in the right direction. You are going to get better care outcomes if people have access to all the information, but you have to have the right interpretation of that. And for me, that is a piece that is often neglected. And it's as much about bringing in all the staff users' perspective into the design of that system, as well as the patient perspective. And I do think my experience is that to move it so that it is properly patient-centered, you do have to recognize the importance of all those people and address their concerns. Otherwise, they will always draw it back to it just being about serving a bricks and mortar acute hospital physical healthcare model. And that's the biggest barrier I've come across, I think, in any of my service design work. I don't know if anybody else.
Yeah, I think I'm delighted that Chris has got some money in Australia, but you can have too much money, especially if it's centrally deposited. I spent my first month's salary as a junior doctor 40 years ago on a Littman cardiology stethoscope. It cost me a month's salary. It was a thing of beauty. It worked wonderfully. I still have it. It's fantastic. And I bought it because the hospital managers were buying my little stethoscope, red plastic, nasty, practically useless, because they didn't have to use it. So you've got to move the money right up close to the people who are going to be using the kit. If not, you get my little stethoscope rather than a beautiful, lifelong lasting Littman cardiology version 4. And I'm slightly filled with horror whenever people get large amounts of money. We had £12.7 billion to spend in the national programme for IT, and all it did was make fat, Geordie, middle-aged psychiatrists sexually irresistible to software sales staff, and truth was an early casualty, and big money warps people's thinking. Very weird. As a psychiatrist, I thought I'd seen the maddest of the mad, but actually the maddest things I saw were when you put £1 billion on the table, what it does to human behavior around it, and it literally warped space-time and morality and truth, and all manner of things, and we ended up spending nearly £3 billion on Lorenzo, which is an EPR, and we got nothing, literally nothing. Didn't end up owning any intellectual property, and they shut the software down 12 months ago. £3 billion, nothing.
Wow. Okay. We need a moment of silence, I think, right now. A little rest in peace here.
I'm not bitter.
we've got Lavi up next, then Craig and Kathleen, if you wanted to jump in. So the chat's really active, so you're doing well, panelists. So yeah, let's go.
Lavi first.
Oh, I just wanted to ask, all of you for your views on the aspect of this contradiction, which is always there. Okay, we spend to develop digitally enabled solutions, but then there is this problem of maintaining engagement. And then we come back to the, a question that you know what, face-to-face is much better. You know, people need human interaction. So again, there is this whole body of, you know, a shift where we said, okay, we need a combination of both, or what many of us think that technology should enable or complement maybe existing human-based treatment plan rather than substitute it. What are all your thoughts on it? Because I've seen many companies falter because of lack of engagement and not being able to, you know, cater or hold on to their consumers because they don't succeed in giving them what they need.
I mean, from my perspective, that has usually been about not being iterative enough and not being responsive to, you know, thinking you do one design and you're done. And again, that also is the problem when you have money at scale and you do it, think it's done, and you do not build in the ability to be constantly evolving your product and your system, because it just makes no sense to think that you're going to spend, particularly in Joe's case, a lot of money and you're done. It's never like that. But that same dynamic plays out if you're a tiny little startup. If you think you've got the solution to that problem and you do that and you're done and you try and go and sell it, you're going to fail, because that is not what any of the companies that I've ever advised, the ones that have been successful, they have been the ones that have been able to adapt and modify it, which also takes money, which is, you know, that's the difficulty. That's always the balance for every company.
I'm a big fan of Professor Margaret Anastat in Oslo. She wrote a book called Working with the Installed Base. And in that book, she explains that actually building a successful digital health ecosystem isn't building. It's gardening, it's cultivational. You water what works with finance and you weed out what's not working, and you grow an ecosystem that can produce a modular healthcare IT system. And that's really informed my thinking and transformed how I thought about what we were doing. People talk about architecture in IT, and it's not architecture. It's about growth. It's about putting things together that suit each other, much more like gardening than architecture. Once I got my head around that, we were able to do some quite cool things in the northeast of England across 3.5 million patch of citizens, which is, I think, I wrote a paper with Margaret actually called Goldilocks and the Installed Base. There is an ideal size for these things, because at the end of the day, there's a thing called the Dunbar number. Dunbar said that you could only really know 120 people, and it's probably the reason why the Romans, you know, had centurions and ranked everybody in 100. The scale of a project, if it gets much above the Dunbar number, they can't know each other, and all IT projects and all digital health systems in the end are built on trust, and that's about human relationships, and I think we forget that. So I take a view that if I can't have everybody in the same pub in an hour, the IT project is too big. And if it's more than 100, you're probably pushing your luck.
Lovely. Thank you. Does anybody else want to come in on that? Well, who was next, Becky? I think after you had...
Well, we've got some comments from Craig and also Kathleen talking about neglecting caregivers in design.
I think go for it.
That's spot on, actually. I think one of the things, having been in the digital health space for too long, 20 years or whatever, why have we hived off health? It's much wider than that. The whole problem, and I think Craig touched on it earlier on, actually, is much wider than just illness. Why have we, you know, hived ourselves off from social care, the voluntary sector? I'm looking at my own 92-year-old mother who's in a care home, looked after by nuns. The Little Sisters of the Poor are not about to deploy Epic, and yet they are key elements of the care system, and they have nothing but email and maybe a PDF or a Word document, and we have no means of bringing them into the multidisciplinary team, even though they're the key carer. So I do think that we've got obsessed with the EPR, and we need to move away to something more like a citizen record, which has all of your stuff in it.
Kathleen, did you want to expand on that at all?
Yeah, I was actually more thinking in terms of familial caregivers as well, and particularly with like digital mental health with youth, parents being a big part of that. So I'm very curious to hear others' thoughts on involving families, because oftentimes they're the ones who are most close to the patients and really there every day and the biggest cheerleaders in terms of engagement.
Well, it's quite, when I was working in virtual primary care, so I was head of mental health and long-term condition strategy, it was quite an interesting area, sort of, groups of consumers that we had. A really big group was, most people had access to this as part of, a corporate employment package. And big groups would be people asking about things like rashes in their children, which it was such a big, important group of patients. And there were lots of kind of friction points with the way the product worked, things like proxy access. So being able to, solving those what feel like quite detailed things was really quite important for that consumer group to be able to carry out what they needed to do. So we needed to be able to make sure that you could access your child's record, you could book appointments. I've actually had a problem with this myself recently, actually, where they've switched over to a new system and all of a sudden I don't have access to my children's accounts anymore. This is major for me. I'm time poor and it is a real pain now that I can't actually access that. And I do think where there is I found it more in industry that we focus on that because we know that those groups are important to the viability of the product. And to come back to one of Joe's points earlier, if it's not close enough, if the sort of literally the proposition drivers like the commercial sustainability is not close enough to your consumer group, those needs get ignored. Hence, we get in more public service type products, we don't get enough focus on those friction points, which will just stop people using it. They can't use it, so they won't. And then what you end up with at a national level is, well, people didn't use X, they didn't use Y. And I'm like, yes, but we need to understand why they didn't use X or Y. And I think that I see lots of examples of that, particularly in that patient carer group, and that lack of focus on that. That's my perspective on it. What do other people think?
I think that's a really interesting point, Leah, around the usability of systems and access. Something that was glaringly obviously admitted from the funding envelope that we recently got handed down was any kind of focus on digital literacy. And I think that that's a really important point, ensuring that the people who are going to be using these systems are geared up to have the technological capability and the digital literacy to be able to use the systems and use them proficiently to make sure that they're used to, to their fullest extent. But back to the standards that Australia's got around digital mental health, one of the standards is ensuring that that consumers have, or their digital literacy is measured when they're brought into a particular service. And I think that that's, a good starting point. But, maybe there's further funding that needs to be sort of targeted towards the broader population here in Australia to bring up that level of digital literacy so they can, fully engage and fully use these services to, to the best of their ability.
Thank you, Chris. Becky, I don't know if there were there were other questions or areas that you wanted to point us to. I do have one in my head if there isn't anything.
Start with that and I'll go through because this chat is fire. So this is all good. Yeah.
So I'm quite interested in people's perspective on the role of charities actually and charity funding within this area. So I've worked with a couple of charities recently who are interested in increasing their footprint, and actually so worked with Barnardo's, which is a charity in the UK. I think they're global, where they work with children who are in need. And building blended services, so digital and in-person, for eating disorders in young people in East London, actually. And I think it's really interesting looking at what and then other charities who are much more in the kind of, so that's actual service provision, other charities who are much more in the field of how do we stimulate the academic environment, or how do we stimulate the marketplace to be providing the right kinds of solutions and systems. Just wondered what the global experiences, or from any of your perspectives, really, what you think that role is? Are there pitfalls? What do people think?
So I'll offer a couple of thoughts that occur to me there. So when it comes to charities, one dilemma is that we view them as outside of the market. So understand that money chases workers and consumers, right? So you're developing anything, and it's not about driving economic development, workers, well, actually, and consumers, got to have someone to make it or buy it. Then that's outside of where the funding chases. Funding chases those two imperatives within a capitalist system. And so you have to always be thinking about that when we're asking these questions about, well, why not prevention? Why not wellness? Why not caregivers? Why not charities? Because they are on the periphery of this focus. And so in some ways, while we may bemoan that focus, we have to also do a better job of rationalizing and developing value propositions that show the funders that bringing these institutions, these parties into the funding calculation so that they too are able to participate and drive outcomes is going to be about showing how they are a part of producing better workers and consumers until we come up with another generation that adopts a different paradigm entirely. It's a regretful dilemma, but it's where we currently sit in terms of what drives the rationale for funding and where money goes. So with charities, I think that, charities are conservative, charities are on the periphery, but not entirely excluded. Like here in the United States, we've got big charities like the United Way, who increasingly but they are highly corporatized. And they have the dilemma that Joe talked about of the opportunism that comes with overscale, right? So you get $100 million or more dropped on an institution. A lot of that money then starts to get siphoned away by middle people, siphoned away by opportunists, because it changes the psyche. It's no longer about the community, social, or clinical outcome, right? It starts to get diluted with other intentions that people have. So this is the fun and the challenge of putting resources into human systems. And I'll stop at that. I went on much longer than I expected to.
I think Craig and I were separated at birth. But the capitalist system drives the creation of monopolies, and when a big company sees a rival come up, they just buy it and absorb it, and that's what's happened in the health tech market. We have an increasingly stagnant marketplace, and if a newcomer comes along, it looks like it might cause problems for one of the incumbents. They just buy it, and you end up with a very stagnant marketplace. Somebody at a conference I was at the other day stood up and asked the Epic rep on stage, when are you going to re-platform your 30-year-old software? And he was kind of stumped.
But, charities are important just because I found 10 years back, right, when digital health, when I started developing this idea, it was too abstract for anybody to understand. And then after COVID hit and everybody everywhere is developing a digitally enabled solution. But the problem is there's this whole mass of people who really need it, but don't have access because they don't have internet connection or smartphones. So our technology needs to be inclusive in the sense, okay, can it be operated offline? Does it need internet connection all the time? Can it be operated on a simple phone? A person may not be able to afford a smartphone, but they are the ones who really need the solution. So that's sort of an issue which I am keen to see more solutions in. One aspect which people in the US have found is that, okay, they are approaching Medicaid to reimburse the usage of the solution so that it can become more accessible to the population who may not be able to afford it otherwise.
That's really interesting, Lavi. So one of the ways I think we've tried to address that in some of the work that I've been involved with is thinking about it in the UK through the lens of clinical safety regulation. And I talk about ethics and safety by design. So in the UK, the clinical safety process that you have to go through is generally, at the moment, a bit of a after the event tick box exercise, actually. And in my view, that is more expensive, and is more likely to lead to more problems. You're more likely to miss big clinical safety issues. And what I very much tried to champion is moving all of that process really upfront, right at ideation phase. Because if you are, just as you've just said, if you are designing a health product that cannot be used offline, you need to stop right there. You do not go any further, because that is going to be unsafe. It is going to be clinically unsafe. So in my view, that does not meet clinical safety regulation. And if somebody brought a product like that to me after the event, after they already, I'd be like, no, I'm sorry, you're going to have to work on all of that, because it is unacceptable for somebody not to be able to access this kind of technology. And I feel that this is one of the problems with that kind of clinical safety, that clinical patient safety knowledge not being embedded with knowledge around the technology early enough in that process. You know, the number of NHS and in industry, people who have a great idea for something, they go with it, but they haven't understand some of that really important nuance up front, and that you end up with a product that is unsafe or doesn't do what it should do. And a lot of that could be dealt with a lot earlier just by engaging earlier. And people often think that costs money. In my experience, it has saved money. It's saved people a lot of money because they don't go down that line in the first place.
I totally agree. That's why I guess having the standardized, which is really lacking, having a standardized set of checkpoints, by either the government or by regulating agency or something, which is there for people developing such applications to see that, hey, are these, have you met these criteria? Then you're good to go. If not, you've got work to do. And that would really, like you said, make it easy down the road and make it more applicable and, save, yeah.
It's much easier to be on paper, producing mitigations rather than after you've done a whole load of dev work.
Right. Totally agree.
We've got 2 minutes left, just to let everyone know if you wanted to.
Sorry, I just wanted to draw attention to Amy's question, I guess, if somebody could offer inputs on that, where she talks about, the challenging issue of comorbidity of mental health and identifying the problem, because ADD kid is diagnosed as ADD by one, but put on the spectrum by another. So that would, anybody, any thoughts on that? And Becky, I know.
Yeah. So can I speak to that quickly? And I'll be brief.
I gotta end it in a minute.
Okay, so this is a very important and emergent consideration in the digital mental health space. In as much as we know, I think I've seen statistics something like easily 25% of any instance of chronic illness will have a comorbidity related to depression and anxiety, just because of the trauma that's involved with it. And so increasingly you see rationale and consideration around how technology and mental health interventions should be a part of the psychosocial support of any chronic illness scenario. And we also see that when that psychosocial support is provided, the adherence to the chronic illness therapy is significantly better, and then you get all of the requisite benefits that go with that. So absolutely, I think that any of us in this space should be thinking not just about how we can offer value to mental health, but how we can offer value to physical, even though that we should get rid of that dichotomy, but you get my point. And I'll stop at that, Becky, because I know you're short on time.
I think that's quite a nice, I'm going to do a 30-second wrap up, Becky. Hope that's okay.
Let's go.
That's a really nice segue into, so that is my area actually, Craig. That's very much where I operate. And for me, it is forums like this where you have multiple perspectives, particularly global ones, and people coming from really different parts of the landscape around digital mental health, that is always where you get the best solutions arising, because we are very, very entrenched in specific models and the ways that we have been trained and learned to work. And we have an opportunity with digital to actually hardwire different ways of doing things. And if we don't take in those other perspectives, we will end up just doing more of the same. We will end up perpetuating the same health inequalities, the same biases. And that's why it's a nice way for me to say thank you, Becky, for bringing us all together, because these are the sorts of conversations that change that. And thank you so much, all of you, for joining us and for the engagement. And I could talk with you all for another 3-4 hours, whatever. Thank you very much, Becky and Joe, for joining us too.
Yeah,